Welcome. Today I'm going to talk about health economics, a tool to maximize health in the real world. I am Jim Kahn, an Emeritus Professor of Health Policy at UCSF. Imagine that you are the health minister in a low-resource nation with $10 million to spend on brain health. Do you build a memory clinic, fund DMTs, that's disease-modifying therapies like lecanemab, subsidize dementia caregiving, launch a public health campaign focused on prevention, or develop a national arts program for seniors? It's a tough choice, right? Such good options. It seems impossible to decide what program most deserves the next infusion of funds, and for how long, which populations, split the funds, cut other programs. This is the classic scarcity and opportunity cost dilemma. With limited, that is, scarce resources, undertaking one action precludes others. Let's look at this slightly more abstractly. Here's what I call a scarcity triangle. In the green rectangle, we see that there are high needs. In the red rectangle, we see that we have finite resources. So we take a set of actions, and this leads to a set of health outcomes. If we were to take different actions, this would lead to different outcomes. And of course, there are lots of possible courses of action. So how can economics help choose among possible actions? There's a conceptual approach called resource allocation. We start with a goal to maximize health. We have resources like health workers and medications that we can assign to different actions, which we call interventions. What's a good mix of interventions? We identify three characteristics. Appropriate means that the interventions effectively address needs. For example, healthy lifestyle advice to prevent cognitive decline, or a DMT to slow progression, or home care to support function. Second, we look for efficiency. Interventions delivered with reasonable resources and prices. And finally, we aim for sufficient, that the intervention set meets the scale of need. Of course, sufficient is tough to satisfy when resources are limited. So we often use economics tools to rank options. We'll return to that later. Importantly, resource allocation doesn't exist in isolation. Let's place it in the broad medical context that you're probably quite familiar with, even if you haven't thought about it exactly this way. We start with disease. There's a pathophysiological process that interacts with risk factors, and this creates disease with associated morbidity, such as dementia, and mortality. Then we can contemplate possible interventions. Effective prevention, treatment, and care can lead to less disease and enhanced health. The resources piece, that's the economics, suggests which interventions are appropriate, efficient, and sufficient to maximize health. And finally, there is policy. We want to shape health systems, programs, and practices to improve health, including equity across populations and diseases. As I said, health economics is the resources component. It is the complement to disease and interventions, and it's a bridge to health policy. Okay, now that we know where health economics fits in the broader scheme and we've defined the types of interventions we want, appropriate to needs and efficient and equitable, let's explore the concepts that economics uses to operationalize the system portrayal. Here's a map. And this is what I call Health Econ Key Concept 1, from financing to health. We start with financing, that is, the money to pay for things. This generates services. We have inputs such as resources, staff who work within the delivery setting, and that might be a clinic. And we have a process, how the inputs are put together to result in services being delivered. All of this leads to outputs or outcomes, that is, health events and health status, both in the aggregate and the distribution among individuals. In summary, money generates services which advance our health goals. How well the system translates financing into health is efficiency. There are two major types of efficiency. Technical efficiency means services are delivered with an appropriate minimum of inputs, technically sound but not extravagant. Allocative efficiency means that the mix of services is optimized to improve health for specified populations and diseases. Okay, here's the last concept slide. Don't worry if it doesn't fully register on this first pass. These are ideas that take some getting used to. In economic analysis, both inputs and outputs have natural and standardized units. Natural units are the heterogeneous events that describe service delivery or outcomes. For example, some natural inputs are physician hours and medicine doses, and natural health outcomes are death, cognition, or mood. These translate into currency and disability-adjusted life years, respectively. We go to the trouble of translating to standardized metrics to facilitate comparisons across interventions and diseases. The fancy metrics are just a way to let us do the resource allocation work. With these standardized metrics, we can compare diseases and interventions and different ways of delivering the same intervention in terms of effects on health and cost. DALYs measure disease burden. One DALY equals the loss of 1 year of healthy life. One QALY, or quality adjusted life year, equals the gain of 1 year of healthy life. This lets us assess interventions in terms of cost per DALY averted or cost per QALY gained. We'll return to this later. Meantime, the DALY show, also on this session's preparation list, delves into the topic for 9 minutes. The GBHI economics curriculum is designed to elaborate on the preceding pillars of health economics, and thus empower fellows, you, to apply economics perspectives and tools. Here's a preview of the curriculum, 7 sessions in all. The first is the intro. That's this session with key concepts and ranking exercises in class. We then look at health systems, how healthcare is paid for and organized across nations. And each of you will develop a summary for your country. Costs and budgets will address how to quantify the resources necessary to deliver interventions and also to implement your own projects. We then have 2 sessions on economic evaluation. The first is about comparing costs and health outcomes, again, using standardized metrics. And the second is an exercise where you prepare and deliver a pitch for a particular program to the Minister of Health. We then look at behavioral economics, how to influence non-rational health behaviors. And many, if not most health behaviors don't follow the rules of classic economics. They're non-rational. More on that in that session. And finally, we end with an exploration of whether you can include economics in your pilot work or the work to follow on after that. I hope you've enjoyed this quick introduction to health economics. I am always available for questions at jgkahn@gmail.com and look forward to seeing you in class.